Part 2 of Chapter 8. The movements that you will be studying in regard to joints is determined by the shapes of the joint surfaces. And in class we will study these movements together and look at the anatomical structure of the different types of joints so that we can better understand how the shapes of the bones determine the degrees of freedom of motion. Recall from Part 1 of Chapter 8 that we have two types of motion: translation and rotation. Translation is a gliding motion along an axis, while rotation is a spinning motion around an axis. If we were to describe rotational movements, we would say that a joint that allows movement around only one axis would be uniaxial, or it allows only 1 degree of freedom of movement. A joint that rotates around two axes is known as biaxial, allowing 2 degrees of freedom of movement, and a joint that rotates around all 3 axes is multiaxial, allowing 3 degrees of freedom of movement. A joint that allows only translational movement, no matter how many degrees of freedom of movement, is called non-axial. Review the axes and the planes associated with these axes, and also review the joint movements before moving on with this video. So if you have not already done so, hit the pause button. Now that we've explained motion through a biomechanical lens, let's look at the different types of synovial joints that there are and the movements that they allow, and be prepared to talk about these in class. Now let's take a look at a specific joint and talk about its special structures and their functions. I have chosen the knee joint because it is the most commonly injured joint in both the athlete and the non-athlete. The knee is a modified hinge joint that is mainly a uniaxial joint. However, its motion is a bit more complicated than the other commonly known hinge joint, the elbow. We will not go into the specifics of the mechanics of motion in the knee because that information is not relevant to our needs unless you plan on going into physical therapy or orthopedics. I have chosen a limited number of structures for you to study and to learn about. Please know the names of these structures, know how to identify them on pictures, and know something about their function. Here is a list of those structures. Let's take a look at this really good picture from your textbook that shows all of the structures that you need to know a little something about. Now within the joint you see these two C-shaped pieces of fibrocartilage. Those are the medial and lateral menisci. And they function to actually deepen the surface to give almost like a little socket to the femoral condyles to articulate with. And so they add some stability to the knee joint. And they also resist compressive forces, but they are prone to injury, especially the medial meniscus. Now let's take a look at the collateral ligaments, and you find those on either side of the knee joint. On the lateral side we have the fibular collateral ligament, also known as the lateral collateral ligament, and then on the medial side we have the tibial collateral ligament, also known as the medial collateral ligament. Now these ligaments become taut during extension of the knee and will resist hyperextension, and will also resist medial and lateral rotation of the knee when the knee is extended. Now the medial collateral ligament is prone to injury during lateral blows to the knee, and we'll talk a little bit about that when we talk about knee injuries. Lastly, we have the two cruciate ligaments. Now these ligaments are named according to where they attach on the tibia. The anterior cruciate ligament attaches on the anterior aspect of the tibia and traverses superiorly and somewhat laterally to attach to the lateral condyle of the femur. The posterior cruciate attaches to the posterior aspect of the tibia, traverses superiorly, somewhat medially, attached to the medial condyle of the femur. Now, both of these ligaments will resist hyperextension, but they also prevent slippage of the tibia on the femur. So the anterior cruciate will prevent anterior slippage, and the posterior cruciate will prevent posterior slippage of the tibia. Now, taking a look at a couple of other pictures from your textbook, this is a super view of the joint, showing very nicely the menisci, the medial and lateral menisci, and you can see how they form almost a concavity for the femoral condyles to sit into, and then you can see the cut posterior and anterior cruciate ligaments here. This is a sagittal view showing the joint cavity very nicely. You can see the anterior and posterior cruciate ligaments, and you can see a bit of the lateral meniscus. You can see the joint surfaces very nicely here as well. Let us switch our focus now to knee injuries and talk about the two most common athletic injuries to the knee joint, the lateral blow and the hyperextension twisting injury. The most common athletic injury to the knee is the lateral blow. And the extent of damage really depends on how much force comes at the knee from the lateral side. So a mild injury in this case may give just a mild sprain of the tibial collateral ligament, or if there's a more severe force coming at the knee from the lateral side, it could completely tear the medial collateral ligament and also tear the medial meniscus. And the most severe of these injuries, you'll get tearing of the anterior cruciate as well. So you'll get a blowout of all three of these in very severe injuries. All three being the tibial collateral ligament goes first, the medial meniscus, and then the anterior cruciate in the most severe. Now this picture from an arthroscopic surgery is showing a tear in the meniscus, possibly from one of these types of injuries. The second type of injury occurs when an athlete plants their foot, hyperextends their knee, and turns quickly and causes a rotational stress on the knee that is hyperextended, and this can tear the anterior cruciate ligament. Our second joint that we will study is the shoulder joint. Now, the shoulder joint is known as the glenohumeral joint, and it's formed by the coming together of the head of the humerus and the glenoid cavity of the scapula. This is a ball and socket joint. However, the socket portion is rather shallow when comparing this joint to the hip joint, and we can see the difference between the two. The socket of the hip joint is much deeper, and this allows for greater stability at the hip than at the shoulder. There's a trade-off though. While the hip is more stable than the shoulder, it's not as freely movable. If you compared the range of motion you have at the hip and the shoulder, you would find a greater range of motion at the shoulder. And that has its benefits, but it also has its drawbacks. Despite having a fibrocartilaginous glenoid labrum that is designed to deepen the socket of the glenoid cavity, it is still only about 1/3 the size of the humeral head. To make up for this lack of stability of these joint surfaces, the glenohumeral joint has an elaborate array of soft tissues that form a cuff around the joint, giving more stability. Still, the shoulder is the #1 joint to dislocate. Now let us look at some of the structures of the shoulder joint that I've asked you to learn about. I've already shown you the joint surfaces and the glenoid labrum. Now the other joint structures that you need to know something about are the glenohumeral ligaments, coracohumeral ligament, the subacromial bursa, the transverse humeral ligament, and the long head of the biceps tendon, also known as the bicipital tendon. We'll talk about the functions of these structures, and then in our muscle unit, we'll study the muscles that stabilize and move the shoulder as well as the knee. The last part of your textbook goes into homeostatic imbalances of joints, looking at common joint injuries and inflammatory and degenerative conditions. And so I will focus that information for you here so that you know what to study. Okay.